So as I mentioned, we see basically a three-stage process that would get you to these goals. And it begins by defining the measures, right? So the goals of defining the measures should be, one, to evaluate performance, right? You need to know how your providers are doing. But you also want to send a signal to providers in terms of the roadmap that they should follow in order to deliver better care or to meet your expectations. And so in selecting measures, there's sometimes a trade-off between, for example, choosing outcomes measures and process measures. Right? Outcomes measures are very useful because they measure the endpoint of the care process, but they don't necessarily help providers understand what they need to do in order to improve care delivery. So an outcome measure might be controlling hemoglobin A1C in a diabetic population, for example. Process measures can be very useful in that they specifically measure whether a provider is doing the right thing. Are they testing for HbA1c in their diabetic population? Are they engaging in interventions to try to manage that population? So they're more descriptive in that sense, but they don't necessarily tell you whether you've gotten to the final destination. So for us, a mix of process and structure measures would be appropriate in terms of creating a measurement strategy. Clearly, there are other considerations as well in terms of defining measures, defining the clinical priorities for your population, where the greatest potential and opportunities lie is important. Being aware of existing measurement programs that your contracted providers might also be participating in is important. For example, if they're in the meaningful use, if they're reporting the meaningful use measures, where you can align your measures with those other programs, it will help to reduce the burden of reporting for providers. And to that point, you also want to consider issues like the complexity of measures, of reporting measures, the cost associated with the reporting measures, and make sure that you're getting a benefit for the cost that you're either incurring yourself or imposing on your network providers. Clearly, a lot of these measurement processes are now facilitated through the use of electronic medical records, the ability to collect information in something approaching real time. And so, again, you want to look at the infrastructure that you have. You want to think about what kinds of measurement it will support in the short term, and then how that needs to evolve over time in order to support the long-term goals of health system improvement. So in terms of the next stage of the process, we start to look at aligning the economic incentives. And here, there are a number of different options to consider. And again, here at Discern, we've worked with groups to implement variations on all of these different systems. In the early stages of care transformation, you might, for example, prefer to stay with a more fee-for-service based model, because that's the model that is being used currently. The infrastructure is in place to implement and apply a fee-for-service model. But then you might supplement fee-for-service with other revenue streams to providers, like a fixed payment that might support some of the infrastructure investments that they need to make, or a pay-for-performance model where they could achieve additional bonus dollars if they conform or achieve certain performance on quality of care measures. Or indeed a shared savings model where you would look at the total cost of care for a population and allow providers to earn a bonus based on whether they have bent the cost curve for that overall patient population. Other forms of other payment reforms that are perhaps a little more ambitious than fee-for-service adjustments would be things such as non-payment for adverse events. This is a model that Medicare has adopted for a number of hospital-acquired conditions that could be prevented. Other payment reform options include warranties, where, for example, the provider wouldn't charge you more if there's a readmission or an avoidable complication. They would rather price that into the original cost. But then they're at risk for any complications that occur. And then as we get into towards the bottom of that slide, these are more advanced payment models. These are models we might envision at the later stages of health delivery transformation, where providers are taking on substantial risk for the cost of care and for outcomes. So for example, there you might look at an episode payment model where you would pay an overall fee to a provider to care for a patient over a specified episode of care or a specified period of time, but then it's the provider who essentially takes on the risk for any cost variation for that patient. Global payment or global capitation is a similar model, but applied at a population level and not just for an individual patient. And then finally, at the bottom of the slide, in terms of hybrid models, it is certainly possible to mix and match a lot of these different systems and approaches together. And in fact, at the end of the day, that's probably what you'll want to do to create a really high-functioning payment system. Because when you think about the influence that you want to have on care delivery, it really depends on the specific type of care that you're talking about and where you hope to achieve better results. So for example, there are certain types of care where whether or not the care is necessary isn't really a question. But when it's delivered, there's high variation in the outcome. So for example, pregnancy and newborn care is a very good example of that, right? There's little doubt about the need for the episode of care, but within the episode of care, we see a lot of variation across providers in terms of cesarean section rates or early elective deliveries. And so there we might want to build a payment model that really focuses on influencing those care decisions within the episode of care. In other cases, you might actually have clinical areas where the need for the episode of care is at question. So the variation is in whether or not the care is delivered in the first place. A good example of that is back surgery, right? So patients who complain of low back pain probably are getting a surgical intervention much more frequently than is actually necessary, or that aligns with the best possible results at the lowest possible cost, right? So where there's a lot of provider discretion about the clinical need for the episode, you would adopt a different kind of a payment model that would focus on the overall utilization decision, as opposed to where you have care variation within the episode. And so for different types of care and different kinds of variation, you can design payment models that address that specific need. So we now are going to transition a little bit to a specific case study around payment reform and care transformation, which is the PCMH model. So as I'm sure many of you are familiar with and in fact have begun to work with patient-centered medical homes, the goals for these systems is improved patient outcomes through better care coordination, more proactive care, and better patient satisfaction by making sure that patients are getting the right care, care that's appropriate for them. And of course, to sustain these improvements over time, which should generate, we hope, net savings in the total cost of care, even if it means that those patients receive more primary care services up front. The idea is that we would avoid expensive hospitalizations, ER visits, other complications associated with chronic illness. And so what we need to do in thinking about promoting that model is to align incentives with effective primary care, which could take the form of fixed payments that the providers would receive to offset their infrastructure costs. It could take the form of incentive payments around shared savings, but it also can take the form of more technical support in terms of data provided to the practices, alignment of quality measurement, and actually direct support for PCMH transformation. At this point, I will turn it over to my colleague Linda Shelton, who does quite a lot of work directly with primary care practices on patient-centered care, for her to provide more background on the PCMH model and some of our work with primary care practices. Linda?
Okay, great. Thank you, Guy. This next slide that says PCMH, a highly organized system, is our graphic conception of how the patient-centered medical home works. And it sort of guides our work in directly consulting with and coaching primary care practices to operate as patient-centered medical homes. So we start in the center with the medical home, the little red house, and always tell them that the medical home starts with you. You need to operate as a team. That means having every member of the team working to the top of their license, and every member of the team understanding and using their direct relationship with the patient. And they reach the patient not just in person, because the patient is only in that medical home a couple of hours out of the year. And so the medical home actually manages their population, tracks what's happening with their patients, and provides access to the patient, not just in person, but via the telephone or the internet. So that's the strongest relationship right there in the middle between the medical home and the patient. And it's a two-way relationship. The medical home doesn't passively wait for the patient to call up and make an appointment. The medical home reaches out when needed to the patient herself and reminds her of things that she needs to be doing, and invites her for needed visits and tests. And then the arrows back and forth from the population represent the fact that the medical home is aware of its whole patient panel and regularly looks at who is in need of or overdue for tests or immunizations or treatment, and reaches out to them, again, actively, not passively. Also, the medical home regularly measures itself on how well it's providing care to that population. At the bottom are the components of the medical neighborhood. You can see that also those arrows go both ways. The medical home very actively coordinates care for the patient throughout the medical neighborhood. But there are no gates and no gatekeepers in the medical home. And you can see there are arrows also directly from the patient to the medical neighborhood. So the medical home, again, actively and assertively takes responsibility for coordinating all of the patient's care, even where the patient makes the decision to go directly to a specialist. And up in the right-hand corner are the things that Guy has been talking about. So all of the opportunities for the medical home to measure itself, compare its quality to others, and be eligible for incentives that health plans like yours provide. And these are growing, as I'm sure you know, across the country in the form of raised fees in fee-for-service, fixed payments to support transformation to the patient-centered medical home, and shared savings. So another big part of the medical home is using today's and tomorrow's tools. So it's pretty hard to do a medical home without an electronic medical record. And in many cases, what we do with practices when we work with them on their medical home transformation is guide them in fully utilizing their electronic medical records, using them for actual measurement of data and producing of registries of patients.